All right, so once again, welcome to our online tutorials. This is part 2 of anatomy. All right, so now let's begin. We have a 45-year-old man who fell on the right knee. He fell on the right knee and felt the acute pain in the joint. On examination, guys, look, there is a severe edema on the anterior surface of the knee joint. There is a severe edema, that is swelling on the anterior surface of the knee joint. Crunching sounds are heard while moving the joint. Crunching sound are heard while moving the joint. Which bone is affected? Which bone is affected? Definitely, you are looking at a problem with what? With the patella. You are looking at a problem with the patella, and the patella is simply the kneecap. The kneecap. And this is a flat, circular, triangular bone which articulates with the femur or with the thigh bone. And it covers and protects the anterior joint surface of the knee joint. It covers the anterior articular surface of the knee joint. So basically, we are dealing with what? The kneecap or the patella. The patella. The patella. And what is your clue over here? Your clue here is what? Severe edema on the anterior surface of the knee joint. The anterior. What's the anterior? That means the cap, the kneecap. So here you are looking at what? C as your likely bone that has been what? Destroyed. During the operation on the hip joint of a 5-year-old child, her ligament was damaged damaged, which caused bleeding. So what ligament was damaged? What ligament was damaged? So they've told you again, there's an operation on the hip joint of a 5-year-old child, and her ligament damage now led to what? Bleeding. So which ligament are they talking about? So over here, you are looking at a ligament that is at the hip joint. At the hip joint. The hip joint. Any ligament that you can find at the hip joint can give you a clue of what the damaged ligament could be. And over here, we are looking at what? The ligament of the head of the femur, also known as the round ligament of the femur. The round ligament of the femur. So again, it's the same as what? Ligament of the head of the femur. Ligament of the head of the femur. Now, femur also means what? The thigh bone, isn't it? So here we're looking at the head of the thigh bone. The head of the thigh bone. And this ligament is located in the hip. In the hip. In the hip. So that's over here. We are looking at what? That ligament. That ligament. So here, A should be our likely what? Answer. The hip joint. Or, yeah, the hip joint. So you're thinking of what? The head of the femur. All right. A 6-year-old child fell on the cutting object and traumatized soft tissues between the tibia and the fibula. Between the tibia and the fibula. What kind of bone connection was injured? What kind of bone connection was injured? Now, if you look at the tibia and the fibula, there is one particular, there's a connection, okay, that connects the tibia and the fibula together. The question is, what is the name of that connection? And the name of that connection is called the interosseous ligament. Interosseous ligament. Interosseous ligament. Which can also be called what? A membrane. So we have the interosseous what? Interosseous ligament. Interosseous membrane. Membrane or ligament is the same thing. Interosseous membrane or ligament is the same thing. But if you talk about the interosseous, it's more of what? The ligament. Another name is the ligament. Is the ligament. Interosseous. That's INTEROSSEOUS. interosseous membrane, interosseous membrane or ligament. I wish I could show you, but unfortunately, I don't have the diagram to show you. But it's a connection between two bones. That's the tibia and the fibula. All right. So here you are thinking of what? Interosseous membrane or interosseous ligament. But don't go for ligament as the answer, but rather what? Membrane. All right. If they've added interosseous, then you can see interosseous ligament. But interosseous membrane is the right answer. So answer is B. Usually the intravenous injection is done into the median cubital vein because it is slightly movable due to fixation by the soft tissues. What does it fix in the cubital fossa? What does it fix in the cubital fossa? So again, they are talking about the median cubital. Now, if you take your elbow joint, you can stretch your elbow joint and look at it yourself. If you take your elbow joint, just decide to flex it. The elbow joint, that's what they're talking about over here. So over here, they are saying that usually during intravenous injection, we use the median aspect of the cubital vein because it is slightly movable due to the fixation of soft tissues. So what does it fix into the cubital fossa? So over here, we are basically looking at what? The aponeurosis of the bicep muscles. So that's what we think about when we look at the cubital fossa. So again, you are looking at what? Aponeurosis of the bicep muscles. So here, your answer should be what? Should be E. Aponeurosis. All right. People are joining in. Okay. Just a second. Somebody's messaging. Okay. All right. So aponeurosis. Victim has elbow joint trauma. Victim has elbow. Again, your elbow. With avulsion of the median epicondyle of the humerus, what nerve can be damaged to? In this trauma, there's an avulsion of the median epicondyle. Of the humerus. What nerve can be damaged in this trauma? Now, I would advise you again, take up your hand, try to stretch it. Open it, stretch it and open it, and let your palm face upwards. When I say let your palm, let the inside of your hand face upwards. Okay, good. Now, assume. Now, if you look at the side that is lateral to you, that is the radial nerve. That is what? The radial nerve. The side that is far from you, that is the radial nerve. Then the side that is median to the body, that is called what? The ulnar nerve. So now, assuming there is a damage of the median epicondyle. Now, if you take your elbow joint, there is some, should I say, how do I put it safe? You can feel the median epicondyle. Let me just say, let's just say there's like kind of a projection of your bone. There's some sort of a projection of your bone. If you look at it, there's a projection of your bone. Medially, there's a projection of your bone. That is called the median epicondyle. So when there's a problem over there, you ask yourself, what nerve passes through the median side of your forehand? What nerve passes through the median aspect of your forehand? And your answer will be what? Of course, the ulnar nerve, because that's where the ulnar bone is. So the ulnar nerve. So over here, we are looking more of the ulnar nerve. All right, so the answer is E, the ulnar nerve. Guys, I would advise those who have Android phones, try and download our medical app called Medent, Medent, Medent. Some of these things you can find the written form of it over there. You can find the written form over there. So try and get the app. All right. A 54-year-old man was admitted to the hospital with complaints of pain in the right subcostal region. Sorry. There is pain in the right subcostal region. There is vomiting with blood. There's an enlarged liver. There are varicose veins in the stomach and the esophagus. Dysfunction of what vessel is likely to be. Is likely to be. So you ask yourself, what vessel connects the intestinal organs to the liver? As simple as that. As simple as that. Because they've told you that there is an enlarged liver, varicose veins in the stomach and the esophagus. That means all these places are all enlarged. So you ask yourself, what vessel is connecting the GIT to the liver? And that is it. And that is it. So you are thinking of what? Yes, the vena porta. The vena porta or the portal vein. The portal vein. The portal vein connects from the intestine to the what? The liver. To the liver. So or hepatic portal vein. Hepatic portal vein. That is what it is. So it basically carries blood from the GIT, the gallbladder, the pancreas, and the spleen to the liver. To the liver. So over here, we can be looking at what? The portal or hepatic portal vein. Hepatic portal vein. Also known as vena porta. Vena porta. Vena porta. So your answer is A. Vena porta. All right. A 2-year-old child presents with physical retardation and a frequent pneumonias. That means lung infection. The child was diagnosed with non-closure of arterial canal. Guys, do you remember when we talk about the arterial, we talk about the patent ductus arteriosus, when I even drew some wonderful diagrams with you guys? Yes, they're saying that this person was diagnosed with a non-closure of the arterial canal. That means they are talking about the ductus arteriosus. The ductus arteriosus. It is still patent, but we analyzed in our last presentation that anytime they give birth or after giving birth, this artery should be what? Closed. Should be closed, because now the baby can breathe on his or her own. So it has to pass, the blood has to pass through the lungs of the baby. So this place has to close so that there will be much pressure to push the blood into the lungs for oxygenation. Isn't it? So now they're saying that there's hemodynamics disturbance in this case is caused by what? So again, what does the ductus arteriosus connect with the study over here? So it connects what? The aorta and the pulmonary trunk. The aorta and the pulmonary trunk. So over here, we are looking at what? At A. Please, I do a diagram on this particular question. One of you asked me and I explain it again. So please, if you've not watched the video, do yourself a favor and get that video and watch it. I drew a very wonderful, I'm being sarcastic. It's not a wonderful diagram, but in my mind, it's a very wonderful diagram. So please try and get the video and then be abreast with what we're talking about. All right. A 5-year-old child was admitted to the otolaryngological department. That is the ear, nose, whatever. And was diagnosed with suppurative inflammation of the middle ear. Suppurative inflammation of the middle ears. That's more or less like what? Maybe otitis media or something, isn't it? Now, disease started from the inflammation of the nasopharynx. That means from the nose to the pharynx. That is where the inflammation started from. And now we are having what? A suppurative inflammation of the middle ear. So as a doctor, you ask yourself, what is the connection between the nose and the ear? The connection between the nose and the ear. And that is what? That's what sometimes when you take in some water and the water is getting you choked, sometimes it can pass through your nose. That should tell you that there is a connection between the nose and the ear. There is a connection between the nose and the ear. And that connection is called what? The Eustachian tube. Eustachian tube. Eustachian. The Eustachian tube. Another name for the Eustachian tube can be called what? The musculotubal what? Canal. The musculotubal canal. The musculotubal canal. That is the connection connecting the nose to the ear. Now they are saying that through what canal of the temporal bone did the infection get into the tympanic cavity? Exactly. So here we are talking about what? The Eustachian tube. Eustachian tube, also known as the musculotubal what? Canal. So here we are looking at what? At A. We are looking at A. All right. Good. Another question on the ear. They say there's inflammation of the tympanic cavity. That's what? Otitis media. Like, so this actually was the previous question. The previous question, the diagnosis was what? Otitis media or purulent otitis what? Media. And I think it was complicated by inflammation of the maxillary process socket. What wall of the tympanic cavity did the pus penetrated into the socket? So over here, we are not talking about a person having what? An infection inside of what? The nose or something that is causing this tympanic cavity inflammation. Over here, we are talking about inflammation of the mammillary what? Process. The mammillary what? Process. So you ask yourself, so the question is that what wall of the tympanic cavity is this? So you're going to look at what? The walls of the tympanic cavity. The walls of the tympanic cavity. So quickly, let's go through the walls of the tympanic cavity. Then we shall know where the mammillary process sockets are located or are found, for which this inflammation is passing through, isn't it? Or has led to what? Its complication. Has led to its complication. All right. So let's talk about it. So one, we have the median wall. The median wall or medial wall. Medial, that's the middle. So the medial wall is also known as the labyrinth wall. This one is facing the inner ear. So this wall faces the inner ear. It faces the inner ear. And that's the wall that has the oval window and then the round window. It has the oval window and the round window. So basically, that is it for the medial wall. Now we also have the lateral wall. The lateral wall, also known as the membranous wall. This is the side that is facing the outer ear. It faces the outer ear. And it is formed mainly by the tympanic membrane. Formed mainly by the tympanic membrane. So that is the lateral wall. The medial wall, close to the oval window, isn't it? The lateral wall, that is what? More or less like the tympanic what? Membrane, isn't it? Now we have what? The roof of the cavity. The roof of the cavity, also known as tegmental wall. The tegmental wall. And this is formed by the tegment tympani. Formed by the tegment tympani. The tegment tympani. Great. We have the floor of the cavity. The floor of the cavity. And the floor is mainly made up of what? The jugular wall, or it is also called the jugular wall. The jugular wall. And this consists of the fundus of the tympani, or fundus tympani. Fundus tympani. That is the floor. Then the posterior wall, or we have the posterior wall, also called the mastoid wall. I'm stressing on it. The mastoid wall. And it is formed by the tympanic antrum, the pyramidal eminence, and the fossa. I repeat, it is formed by the tympanic antrum, the pyramidal eminence, and then the fossa, and then the fossa, and then the fossa. That is the posterior. And again, another name is called what? The mastoid, the mastoid, the mastoid. Then we have, last but not the least, the anterior wall. The anterior wall is also called what? The carotid wall. And this corresponds to the carotid canal. It corresponds to the carotid canal. So over here, we are talking about the mammillary what? Process socket. The mammillary what? Process socket. So over here, we are looking at what? The mastoid process. And so therefore, we are looking at the posterior wall. The posterior wall. And that is why here, your answer is D. The posterior wall. The posterior wall. The posterior wall. All right. A 19-year-old female suffers from tachycardia in the rest condition. Suffering from tachycardia in the rest condition. There's weight loss, excessive sweating, exophthalmos, and irritability. Even if you can't remember anything, remember exophthalmos. That is what? Bulging of the eye. Bulging of the eyeball. Bulging of the eyeball. And basically it is caused when there is what we call thyrotoxicosis. Thyrotoxicosis, or when there's too much of what? Thyroxine in the blood or in the body. Too much of what? Thyroxine can cause what? Thyrotoxicosis. Thyrotoxicosis. Too much of what? Of thyroxine. So over here, we are looking at what? Tyrosine. 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 So your answer is D. Tyrosine. Why? Because we are looking at a problem called what? Thyrotoxicosis. Thyrotoxicosis. That these people are heat sensitive. When we say heat intolerance, meaning that they do not like what? Heat, because they're already feeling hot. So they don't want what? Heat. That's why they are sweating profusely. Sweating profusely. All right. And they can easily have diarrhea. And that's why there's what? Increase in weight loss. Increase in weight loss. All right. So the answer is D. A 60-year-old patient was diagnosed with hypothalamic lateral nuclear stroke. So here, yes, there's a stroke. And when we say stroke, we are referring to what? Inadequate supply of what? Blood to the brain tissues. And as a result, the brain tissues are going to what? Paralysis, isn't it? Now look at it. What changes in the body's behavior may be expected? What changes in the behavior may be expected? So you ask yourself, what is the function of the hypothalamic lateral nuclei? Hypothalamic lateral nuclei or lateral area. What is the major function of this? So when there's a problem over there, what can it lead to? What can it lead to? So basically, it leads to cognitive or it leads to an array of cognitive and physical what? Processes, such as feeding behavior and arousal, reducing pain reception, regulating body temperature, digestive functions, blood pressures, among many, many others. Among many, many others. However, what changes in the body's behavior may be expected. Now, if you look at all of these things, all of them may be what? Expected. All of them may be what? Expected. However, I don't know if the question was trying to refer to the cause of it. Basically, to lead to depression, behavior, everything is there. Everything will be there. But definitely, it will lead to what? But the third Krok says the answer is what? Rejection of food. But of course, you will lose what? Appetite. You are going to lose what? Appetite. You're going to be depressed. There can be aggressive behaviors and so on and so forth. And so on and so forth. But there can be what? Reduce pain perception. So you might not feel pain because there's stroke. you might not feel pain because there is stroke. So over here, we are looking at anorexia or rejection of food. Rejection of food. That would be more ideal. That will be more ideal compared to the rest. Of course, it can lead to depression as well. It can lead to depression as well. So over here, your answer is what? Is D. Rejection of food or anorexia. All right. So your answer is D. The process of heart transplantation determined the viability of myocardial cells. The determination of what myocardium parameter is the most important. Is the most important. So again, the process of heart transplantation determined the viability of the myocardial cells. In other words, the condition of the heart, you're able to determine it, or when there's a heart transplant, it helps us to determine the viability of myocardial cells. But what is the determinant, or how do you know that this myocardial cell or the cardiomyocyte are good cardiomyocyte, or yes, are good, or is important to help you to know the functionality of the myocardial cells? And here you are looking at what? The resting potential. You are looking at what? The resting potential of the cardiomyocyte. The resting potential of the cardiomyocyte. Because if you know the resting potential, you will know that yes, this is the threshold of this cardiomyocyte. Does it correspond to the norm, or it doesn't correspond to the norm? Do you take a long time before it can generate impulses? Because don't forget, this resting potential talks about the what? The automaticity of the heart, meaning the ability of the heart to be able to generate what? Impulses, so that it can contract and relax. All right? So that it can contract and relax. So here we are looking at what? The resting membrane potential of the cardiomyocyte as our parameter for determine the viability of myocardial cells. So here we are looking at the rest potential of the cardiomyocyte. That is what? C. All right. It is necessary to take cerebrospinal fluid from a patient with suspected inflammation of the brain tunics. Basically, meningitis, of course. Meningitis. So in meningitis, you must always take CSF or cerebrospinal fluid. Now, diagnostic puncture was performed between the arcs of the lumbar vertebra. That is the T3 and the L3 and the L4, if I'm correct. That is where the lumbar puncture is usually done. Now, during the puncture, the needle went through the following ligament. So you ask yourself, what ligament can be found adjacent to these places, or can be found over there? And over here, you are thinking of what? The yellow or the flavor ligament. The flavor ligament, which is what? Which is A. Or ligamentum flavum. Ligamentum flavum. This is a short but a very thick ligament that connects the lamina of adjacent vertebra. That is from C2 to S1. C2 to S1. And it is the widest in the lumbar region. It is the widest in the lumbar region. So at times when you do a punch over there, you can hit on this what? Ligament. So over here we are looking at what? A. Ligamentum flavum. Nowadays, about 50 minor bases have been found in the tRNA structure, that is transfer RNA structure, besides the main four. So choose the minor nitrogenous what? Base. Choose the minor nitrogenous base. So already you guys know about AGCU. AGCU. You guys know about this, or you should know about this, where we have the adenine, the guanine, the cytosine, and then the what? The uracil or uracil. Uracil. These are the four main nitrogenous what? Bases. The four main nitrogenous bases. Now in RNA, the uracil binds to the adenine. The uracil binds with adenine. So these two will bind, these two also what? Bind. That is how the pairing is normally what done. But like I said, the minor one will be what? Dihydrouracil. So sometimes we can have this dihydrouracil. This will be what? The minor one. Because of course, I've told you guys all these things are what? Major. All these things are major. All right. So here we're looking at what? At E. Please, this is not part. This cysteine is not part. It's cytosine. It's cytosine, not cysteine. It's cytosine. But the minor one is what? Dihydrouracil. So your answer is E. Your answer is E. Obstructive jaundice developed in a 50-year-old. Obstructive. What do you mean by obstructive is post-hepatic jaundice. Post-hepatic jaundice. Don't forget, we have three types of jaundice. We have the what? The pre-hepatic, the hepatic, and then the post-hepatic or obstructed hepatic. Obstructed jaundice. Jaundice. Obstructed what? Jaundice or mechanic jaundice. They all mean what? The same thing. So they say that this thing developed in a 60-year-old patient because of a malignant tumor of the big papillary of the duodenum or duodenal lumen of what anatomical structure is squeezed with this tumor. So you ask yourself, around this area, what structure will be what? Squeezed, for which we are having this obstructive what? Jaundice. And of course, you are looking at the hepatopancreatic ampulla. Hepatopancreatic ampulla, because that is the same area whereby you can find this papilla. So when this papilla is going in big inside because of the tumor, of course, it can block this ampulla. And this ampulla drains directly into the what? The duodenum. They drain into the duodenum. So when this place is blocked, that means that things can happen, isn't it? So over here, we are looking at what? Hepatopancreatic ampulla. That is what? B. All right. A patient with thymoma, that is thymus gland tumor, has cyanosis, extension of the subcutaneous venous neck, and edema of the soft tissues of the face, the neck, the upper part of the trunk, and in the upper extremities. What venous trunk is pressed with the tumor? So now you ask yourself, what supplies or what drains from the superior vena cava and then the inferior vena cava, isn't it? That's the questions, or these are the questions that will be what? Coming into your mind as a doctor or as a physician. So they're talking about the upper part, the head, the neck, blah, 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 blah. So over here, you are thinking of what? The superior vena cava. You should be looking at what? The superior vena cava. Superior vena cava or vena cava. Superior vena cava. So your answer is A, superior vena cava. Because this is what drains or brings or retain deoxygenated blood from the systemic circulation to the right atrium of the heart. The inferior one will also bring the ones from beneath or from the lower extremities, the abdomen, blah, 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 brings them up to the heart for oxygenation. So this tumor will compress this superior vena cava. So your answer is A. A patient operated on a complicated appendicitis has the following changes of blood count. 4 times 10 to the power 12. Hemoglobin is 120. Color index 0.9. These are actually what's quite okay. But look at the leukocyte, 18. It's supposed to be between 4 to 9, or even some say 11. By 18, So tell you that there is what? A serious infection taking place over there. Basophils are 0, eosinophils are 0, myelocytes are 0, stap juvenile are 0, stap neutrophils are 0. Sorry, stap neutrophils are 20. Then segmented are 53. Lymphocyte 21, monocyte 5. How is such nuclear shift of leukocytic formula called? Guys, we have talked about the types of shifts in our previous presentation. Please do well to watch the video where we talked about the generative shift and the degenerative shift. And we made mention that anytime there is a left shift, it shows that there is the presence of immature neutrophils. There is a presence of immature neutrophils in the blood. In the blood. And this indicates what? An inflammatory process. An inflammatory process. That is what we call the left shift. The left shift. Great. So now, when the absolute numbers of the immature, or when the immature neutrophils, I repeat, when the immature neutrophils are greater than the mature or the segmented neutrophils, we call it degenerative left shift. We call it degenerative left shift. Now, the opposite is true for regenerative left shift. Regenerative left shift. So now, when we talk about degenerative left shift, it is used in the context of neutropenia. Neutropenia, or when there is low amount of neutrophils. When there's low amount of neutrophils. When there's a low amount of neutrophils. And why would there be a low amount of neutrophils? It means that inflammation is quite severe. It's quite severe. Now, when you look at the stap neutrophils, we have 20. Segmented is 53. Now, you're not supposed to have this kind of stap neutrophils too much like this. You need to have segmented neutrophils supposed to rather be more high. Although relatively it is high. But with a high number of immature cells, definitely we are looking at At a degenerative left shift. We are looking at a degenerative left shift. Degenerative left shift. So over here we're looking at At A. We are looking at A. Please, once again, try and go through the videos that we have already done. Try. Because I went in details over them. And I think someone asked a question again, and I repeated it again and again. So please do well to watch it. All right. Now, a patient complains of a frequent and difficulty urination. Imperfection of what function can cause this? Guys, there's difficulty to urinate and difficulty in urinating. That means that something is blocking the release of the urine. Something is blocking the release of the urine. And in men, what can cause this is the prostate. So we're looking at at a BPH or a prostate cancer. So again, we are looking at a prostate. Apart from that, infection can cause, of course, frequency and then the difficulty urination. But apart from infection, what can cause or what structure can cause it is the prostate gland. The prostate gland. So over here, we're looking at D, the prostate. The prostate. Child inspired a button. Where is it likely to be? So the bottom of your shirt fell down, your child took it. Where do you think it will go to? Of course, it will go straight into the right main bronchus, because first of all, the right main bronchus is shorter and it looks like it is in a straight line with your trachea. Unlike the left one, which is more bent. It is more bent, or it is more away, or it is more curved than the right one. So when you inject something, usually we are looking at it in the right lungs. So basically, we are talking about the right main bronchus, the right main bronchus. So your answer is what is D. Now let me just give you a small diagram. So this is like this. Then we have this. Then we can, so this is the trachea, okay? This is the trachea. Then in this is the right side. Now in the left side, you can have this. You see? You see? So you ask yourself, when a substance is entering here, where is this is the trachea, okay? This is the trachea. I'm trying to draw the circular ring or the cartilages, okay? Now, when a substance enters here, or when anything enters here, definitely it will flow more to this side than that side, isn't it? And this is what the bifurcation. The bifurcation. So over here, we're looking at what? The right main bronchus. All right. Vegetative abnormalities in the sleep, heat regulation, all kinds of metabolism. Diabetes insipidus are developing in the patient due to growth of tumor in the third ventricle of the brain. The third ventricle of the brain. Irritation of the nucleus of what part of the brain can cause such symptoms? Can cause such symptoms. Okay. So we're looking at the part of the brain that controls majority of all of these things, like heat regulation, like metabolism, like diabetes, like sleep, all of these things. Basically, we are looking at what? The hypothalamus. The hypothalamus. Hypothalamus. This hypothalamus, though it is very small, but it can control a whole lot of things inside the brain. It can control a whole lot of things inside the body. Hypothalamus. So your answer is D. Hypothalamus. So basically, it is involved in metabolic processes and other activities of the autonomic nervous system. Autonomic nervous system. So it can lead to disturbance in sleep, sexual functions, and so on and so forth. So over here, that is what we are looking at. So your answer is D. A patient is suffering from infectious mononucleosis. Infectious mononucleosis has been taking glucocorticoid for 2 weeks. That's cortisol. Cortisol produced by what? By the adrenal gland. Which part of the adrenal gland? The middle layer. Please don't let me go through this thing again. We have the GFR, glomerulosa, fasciculata, then reticularis. All of these things have the kind of hormones that they produce. Don't let me go into these things. Please do watch the videos, okay? Now, this resulted in a remission. That the patient got exacerbation of chronic tonsillitis. This complication is induced by the following effect of the glucocorticoids. So you know that glucocorticoids is also what's called, it is also a immunosuppressive. So when the immune system is low, of course, other diseases are likely to come on board, isn't it? Other diseases are likely to come on board. Of course, it is also anti-inflammatory, anti-shock, anti-allergic, and stuff like that. But again, for the reason for which there's a remission and then there is a infestation of tonsillitis, you are thinking of what? The immune system being low. You are thinking of the immune system being low. So over here, what comes to your mind is immunosuppression or immunosuppressive. Immunosuppressive. All right. A 45-year-old man with a domestic upper arm injury came to the trauma unit. The objective data are there are no extension, abduction, or pronation functions of the arm. What muscle damage caused this condition? No extension, no abduction. Adduction, that means you can't move the arm towards your body. And then you cannot take your hands backwards. Extension. And then you cannot rotate your hand. That's pronation. You can't rotate it. So what muscle are they talking about? So you look at the muscles that are involved in the shoulder joint. Shoulder. They said upper arm. So we're talking about the shoulder area. So over here, what comes to our mind is what? the teres major, because that is a very thick muscle of the shoulder joint, okay, of the shoulder joint. So that is what we are looking for. And it is involved in what? It assists in extension and the medial rotation of the humerus. It assists in extension and medial rotation of the humerus. Humerus is a bone, please. I mean, your upper arm, the bone inside is called humerus. So don't get confused. So we're talking about the teres major. Teres major. So the answer is E, teres major. A man with internal abdominal right side injury, and suspicion of a liver rupture was admitted to the department. In what peritoneal structure would the blood accumulate? Where will it accumulate? There's a suspicion of liver rupture. There is a suspicion of a liver rupture. So you think of maybe a small hole, or let me say a small excavation, or let me say a small pouch, where when there's an injury, these things easily gets lodged in over there. So over here, that is what comes to mind. Don't forget again, there is an internal abdominal right-sided injury. And a rupture. A suspicion rupture of the liver. So where would the substances enter, or where would they go to? So over here, we are looking at the rectovesical pouch, also known as excavation rectovesicularis. And this is a pocket that lies between the rectum and the urinary bladder in the males and in other male mammals. And it is the lowest part of the peritoneal cavity. And usually, peritoneal fluid and other fluids that enter the peritoneal cavity, including ascites, blood, and pus, tend to collect in this pouch. Like I said, it is the lowest part of the peritoneal cavity. So any fluid, any blood, anything that you see inside the peritoneal cavity will eventually drain into this pouch. So
momentalis, what are you saying?
Is that proper?
Someone's microphone is on. Please mute your microphone. Okay, thank you, doctor. All right, so like I said earlier on, we are looking at this pouch, rectovesical pouch. Now, in females, we do not have this rectovesical pouch, but instead we have rectouterine pouch, or vesicouterine pouch. So that's the same thing as the excavation rectovesicalis in males. It's the same thing. So you're looking at that pouch. So over here, we're looking at at E. We will look at E. We'll be looking at at E. All right. A histological specimen presents parenchymal organ, which has a cortex and a medulla. Good. Cortex and a medulla. The cortex consists of epitheliocyte bars with blood capillaries between them. The bars form 3 zones. Guys, look, 3 zones. Medulla consists of chromophenocytes and then venosynoids. What organ is it? Of course, the gland, the adrenal gland. Where we have the GFR, glomerulosa, fasciculata, and then reticularis. I was talking about it some few questions ago. Then we have the medulla, isn't it? Now, all these parts produce their own kind of hormones. The first part, the glomerulosa, will produce what? Mineralocorticoids or the aldosterone. The middle part of the zone will produce what? Corticoids. And then the inner part will produce what? The male sex, or let me just say sex hormone. No, not male. Basically, the sex hormones. And then the medulla will start producing what? Catecholamines, like the epinephrine, the norepinephrine, and all those kind of things. Please, we have discussed these things in previous presentation. Do watch them. All right. So here we're looking at what? The adrenal gland. The adrenal gland. After a trauma, a 44-year-old patient had a rupture of the left palm muscle tendons, and of the surface of the blood vessel. After operation and removal of most part of the necrotically changed muscle tissue, the bloodstream was normalized. What vessels have helped with restoration of bloodstream? What has helped in the restoration of blood? What has helped in the restoration of the blood? Now, when you look into your palm, you can take your palm again. Just check inside your palm. Now, the deep layer of the palm, or the arc, there's an arc inside the deep layer of that palm that you have. So we call it profundus. Profundus. That is the vessel that is helping in restoration of, or making things come to what? Normal. Making things come to normal. So we call it the deep palmar arc. The deep palmar arc. The deep palmar arc. So this undergo to call anastomosis in the deep compartment of the hand. In the deep compartment of the hand. So please take note of that. And what does it do? It provides blood supply for the bones, the joints, and in the deep muscles of the hand. That is the main function of this arcus palmaris profundus, or the deep palmar arc. The deep palmar arc. So your answer is B, deep palmar arc. A 45-year-old man applied to the trauma unit because of a domestic shoulder trauma. Again, guys, do you remember we solved a question that is similar to this? There is what? A shoulder trauma. Flexibility, reduction, and pronation functions of the shoulder are absent. What muscle was injured? What muscle was injured? So again, you think of the muscles that are involved in the shoulder joint. And the thickest one is called what? The teres major. So here we are looking at A. We've solved something like this already. We are looking at A. We are looking at A. There's no flexibility, no pronation, everything is absent. So we are talking about A. All right. Ovarian tumor was diagnosed in the woman. Surgery was indicated. What ligament should be cut by the surgeon to disconnect the ovary and the uterus? The ovary and the uterus. So, of course, we are looking at the ovarian ligament. The ovarian ligament, which is also called utero-ovarian ligament. You see, so because Krok wants to confuse us, they wouldn't bring utero-ovarian ligament, but they will bring what? The ovarian ligament. It's the same thing. So we're talking about what? The utero, that is the uterus and the ovary, or proper ovarian ligament. That's another name, proper ovarian ligament. And this connects the ovary to the lateral surface of the uterus, to the lateral surface of the uterus. Over here, we are looking at what? At the ovarian ligament, ovarian ligament, ovarian ligament. That is more like it. All right. Now, the round ligament, in case you're talking about it, is a structure in the pelvis that supports the uterus, okay? And it connects the uterus to the groin region. So it has gone down into what? To the ovary. That is the round ligament. All right. Good. An old woman was hospitalized with acute pain, edema of the right hip joint. Edema of the right hip joint. The movement in the joint are limited. Which bone? Old woman. I've said it again, I've said it and I'm saying it again. Anytime old people fall or there's a trauma in an old patient, maybe they're saying there's a fracture in the hip joint, please know that the part of the thigh that is very, very prone to injury is the neck of the femur. The neck of the femur, the neck. And that can lead to what? Problems with movement. So over here, we're looking at what? The neck of the femur. I've said it and I'm saying it again. All right. Old woman or old people, think of neck of the femur. A 53-year-old male patient was diagnosed with a liver rupture. Guys, look at it. A liver rupture resulting from a blunt abdominal injury. The escape blood will be assembled in the following anatomic function. Guys, we've done this. But over here, they are referring to what? A woman, not a man. They are referring to what? A woman. And I've told you guys that we have what we call what? The rectovesicular porch. That is for male. And then in female, we have what? The rectouterine porch. Rectouterine porch. So over here, our answer is what is A. We've said it. In males, we have the rectovesicular porch. In females, rectouterine porch. And why? Because this is the lowest part of the peritoneal cavity. And anything that drains into the peritoneum will eventually settle down in this pouch. So please, there's no confusion in it. So the answer is A. A patient complains about edema of the legs, cyanosis, small ulcers on one side of the lateral epicondyle. Examination revealed swelling, enlarged veins, and formation of nodes. The pathological process has started in which vein? In which vein? In which vein? What are they referring to? What are they referring to? Now look at it again. They said there's edema of the leg, cyanosis, small ulcers are formed. There's swelling, enlarged veins, formation of nodes. So what are we looking out for? What are we looking out for? Definitely, we will be talking about what? The superficial veins of the lower limbs. The superficial veins of the lower limb, which gives rise, of course, it gives rise to the great and then the small saveinous veins. Now, the small saveinous vein is called what? The vena saphenna parva. The vena saphenna parva. And this arises at the lateral aspect of the foot. The lateral aspect of the foot. And over here, they say what? There are small ulcers on one side of the lateral epicondyle. Lateral epicondyle. So that comes to our mind. Now, the great saveinous vein arises from the medial portion of the dorsal venous network. It arises from what? From the median. So this will be median. This will be what? Lateral. Isn't it? But both of them are superficial veins. So what comes to mind? Of course, we are looking at what? At D. We are looking at what? D. The lateral aspect. The lateral aspect. The lateral aspect.